Thank you for joining in the No Podcast series. In this series, you'll be hearing a wide variety of brilliant minds around the world that are working at the forefront of sport and exercise medicine to see what can be learned from their career and their experience. We talk about a range of topics to foster learning, inspiration, and innovation, and provoke conversations that can dictate the future of sport and exercise medicine. My name is Nirmala Pereira, and I'm your host. I would like to begin by acknowledging the traditional owners of the land which we meet today and pay my respect to their elders, past, present, and emerging. I wish to also recognize the outstanding contributions that Aboriginal and Torres Strait Islander people make to sport in Australia and to celebrate the power of sport to promote reconciliation and reduce inequity. Our latest guest is Dr. Mathew Mooney. Dr. Mooney is a medical practitioner and industry PhD scholar at the Australian Institute of Sport and University of Canberra. He is investigating infectious diseases in athletic populations. Welcome to the podcast, Matt.
Thanks, Nim. It's good to be with you today and to have a chat.
So, Matt, by way of introduction, can you give us an idea about how you ended up at the AIS?
Yeah, I guess in terms of at the AIS, it's sort of the combination of quite a number of things where I sort of started out growing up in country Victoria and socialised heavy into sport when I was sort of very young and always very interested in the how to get a little bit faster, how to perform a little bit better and how things work. And then in terms of, you kind of tend to gravitate with people that you enjoy working with and enjoy fitting in with. So that's sort of how things kind of started out. And I initially started out in sports science, and strength and conditioning was kind of how I started out.
Yeah. And what initiated your change from science to medicine?
In terms of like sports science, I guess there's no real defined career progression from that. And I sort of branched out after I finished my initial undergraduate studies and had worked in different areas like in IT, in rehab. I worked for the Transport Accident Commission for a little while, and then sort of made the decision to go to medical school after that. But it was sort of, I guess, working at the Transport Accident Commission with their clinical panel and getting to see that mix of the scientific thinking, the problem solving, helping people as well. So it was a good sort of mix for me, I found.
And your interest in infectious diseases?
I guess with a lot of things, you sort of tend to, I almost sort of not fell into it, but got a bit lucky in that when I finished my medical school training in Wollongong, I moved to Canberra and I took an internship there, and I didn't deliberately choose it, but I ended up being allocated an infectious diseases rotation at ACT Health, which I absolutely loved. And at the end of my internship year, I really enjoyed the collegiality, the types of problems that we were working on, the thinking that was involved in solving them, and being able to sort of define problems and treat them. And it was probably my favourite rotation from my internship, and that sort of stuck with me thereafter.
You're also an athlete as well.
Yes, I'd say I'm more of a part-time athlete. Where during medical school, I took up track sprint cycling and sort of managed to squeeze in a few races at sort of like elite track nationals, but I would say that was very much a hobby on the side.
That's a good hobby to have. Can you tell us a little bit about what do you see as key career choices you made thus far? Because you have a pretty broad experience in different areas.
Yeah, in terms of my career choices, I think it's about, I don't know, like even sort of doing sports science, taking on lots of field work and having practical experience to go along with all of the book learning. I think that the infectious diseases rotation at ACT Health was quite pivotal. And then towards the start of last year, end of the year before, I was fortunate enough, so the AIS were looking for clinician PhD scholars. And I came across and had discussions with Mick Drew from Athlete Availability, and he was interested in looking at the way sort of illness affects athletes. A lot of work has been done in injury, but not as much has been done in the illness space. So he was with Gordon Waddington was able to set up a PhD scholar program where I was able to do sort of 50% clinical, 50% research work at the AIS and with sports medicine as well under David Hughes, which has been great. So since taking that on at the start of last year, I think that's sort of where things have started to snowball from there.
and what attributes have helped you to get to where you are now?
I think in terms of having a wide set of interests, so in terms of, working in different areas such as IT or, sport, it hasn't sort of been a narrow focus in sport and high performance sport. That's kind of just sort of where I've luckily ended up at the moment. And it's been, I think, really sort of having experiences in different areas of healthcare, different areas of sport, from, being like on the coaching side of things and sort of a little bit being an athlete, and then sort of being the clinician as well. So it helps you piece things together. But I think probably the most important thing for me is the innate curiosity, and you're always sort of trying to understand why and piece things together, and not taking things on face value, I think has been one of the key things for me.
Yeah, thank you, Matt. Now to the topic of this podcast, COVID-19, and you were instrumental in contributing to the AIS framework, as well as you wrote up a paper about testing and management of COVID-19 that was published on JSAMS. The virus has been in the news nonstop for a long time. So it's been around, it feels like it's been around for a long time, but COVID-19 is a very new disease, and we are still learning about the way the virus spread, how it affects our body, how the body responds to the virus during and after the infection. To set the scene, given that evidence is rapidly evolving, can you give us a brief overview of COVID-19?
Yeah, so in terms of how it transmits, so it's primarily a respiratory tract infection, and it's the primary mode of transmission is through respiratory droplets. The evidence at the moment seems to be growing in terms of the contribution of aerosols, and there's also potential other mechanisms such as a fecal oral transmission, but the evidence in that area is a lot more sparse, and it's more theoretical. But the idea or the concept is that viral particles from an infected individual will then come in contact with like the mucosal membrane, so inside the nose, the mouth, the oropharynx of a potentially susceptible person, and then kick off the infection from there.
Can you touch up a little bit about the long-term consequences?
Yeah, so the long-term consequences are something we're just starting, I think, to see the tip of the iceberg on. But the more we're learning that this is a multi-system disease with some likely persisting effects. So they will cross from, say, like autoimmune illnesses. There's been some reports of like a rheumatoid arthritis type syndrome. Myocarditis. There was a recent paper in JAMA Cardiology where in Germany, 100 people who had recovered from COVID all had cardiac MRIs, and in 79% of them, they found evidence of myocardial damage on MRI that was attributable to COVID, and something in the order of 60% as well had myocarditis, and that was independent of the severity of illness or previous comorbidities. So these studies are starting to come out, and there's evidence mounting that it's quite an important component, and we need to think about the long-term consequences. There's other complications such as like a hypercoagulatable state resulting in pulmonary embolus, some strokes and DVT. There are other reports of neurological manifestations with some adult onset seizures. And the scary thing about it, I think, or the concerning bit at this stage, is that it doesn't necessarily seem to be confined to the very sick and those that are only admitted to ICU. It seems to be appearing in those cases that are well enough to be considered mild or managed in the community. So
how does that impact athletes? Because there are reports some athletes have contracted COVID-19.
Yeah, that's a really interesting one, because and it would require a specific focus in the research area to actually tease that out, because the typical measures that we use are morbidity and mortality, and athletes being young, fit, healthy, by definition, will do really well in the mortality statistics. They have the highest lung capacities, the best cardiovascular health by and large. But the thing is for them as well that they need their physical capacity to earn a living, to do what they love, and that's where we sort of need to focus our research a little more. So the chances of a COVID infection, even a mild one, having some long-term impacts on their performance, or like a rate limiter on their performance in the long term, is quite real, and we don't really know the extent of that at this point.
And another tricky part with COVID-19 is the virus's ability to asymptomatically transmit. Can you talk a little bit around that, please?
Yeah, so the asymptomatic transmission is been in part what separates SARS-CoV-2 from previous coronaviruses, and is what has made it so difficult to contain from a public health perspective. So asymptomatic transmission occurs when the infected individual has not yet developed symptoms or something that they would recognise as symptoms, and they have a viral load that's sufficient enough to infect another individual. Now, the concern, and particularly with SARS-CoV-2, is that you tend to be most infectious around that time of symptom onset. So even in that sort of 24 to 48 hours prior to symptom onset to just after symptoms onset, that's when you're maximally infective. And that also coincides with when you're feeling well. You may well be participating in your usual daily activities at that point as well, exposing other people without ever knowing it.
And also currently there's a lot of talk around community transmission. Can you explain why that's a problem, especially in sports settings?
Yeah, so community transmission refers to like a locally acquired case for which they don't really know where it's come from. So it would be like after there's an effort for contact tracing to try and tie your exposure back to a known case or through genetic studies, and they've still don't know where it's actually come from. So at that point, the assumption is that you've contracted the case going about your usual daily activities in the community. Now, for sport, that means that's indicative of that there's a reasonable chance that somebody could be in the group that may have very, very minor symptoms or not know they have any symptoms, and then that could represent a transmission risk in the sporting environment.
Proactive risk management strategy or having a COVID-19 safety plan to reduce the risk of transmission in sporting environments is important, and that should include testing. So let's focus on next part of the podcast on testing for COVID-19. Can you tell us why testing is important and what can testing tell us?
Yeah, so testing's particularly important at a community level is because it helps you to be able to understand the prevalence of the illness, where it is and where the risks actually lie. So in terms of is the scenario improving, are the public health, are the lockdowns, the masks wearing, whatever interventions are being used at any point in time, are they effective or are they not sufficient at that point in time? So it helps to inform the overall public health measures. On an individual basis as well, it helps to inform there tends to be about a 20% concurrent infection rate as well with COVID-2. So there may also be a treatable infection along with COVID at the time. So are there other medications that you might require? And it also helps to work out what sort of period that you may be infectious for. So how long do you need to stay off work? How long do you need to stay away from training? What further follow-up testing might you need, such as the cardiac MRIs and further neurological workup if you do happen to have a COVID screening. So it helps to direct treatment and also provide intelligence at a community level in terms of where the risks are, and so that we know about what protection measures are required.
So in terms of testing, we know that there are two types of testing. Can you explain to us what these tests are and how they work?
Yeah, I guess the two types of tests that are talked about in the media and generally are PCR testing, which is considered can be considered the gold standard testing, I guess, because viral culture isn't really used a great deal, but it's the most commonly used diagnostic test that we have. It is very, very sensitive. And the basics of it is it amplifies a known specific segment of the RNA of the virus to copies that are, to numbers of copies that are detectable through a fluorescent probe. The other type is a serology test. And with serology testing, what they're looking for is the body's response to COVID exposure. And that usually takes about, sort of 10 days or so roughly to mount an antibody response, which can then be measured via what's usually like an ELISA assay, or they've got also the lateral flow test, which appears similar to like a pregnancy type test, a home pregnancy kit test. in terms of the actual test characteristics as well from either. So PCR is quite useful because that will tend to be positive very early in the illness, and that actually has the potential to be positive prior to the onset of symptoms because you have an increasing viral load which is detectable, and then symptoms can occur. So that it's thought sort of in that sort of 24, 48 hour period, there's a chance that PCR testing could be can pick up cases, but it's not that's not always the case. Whereas serology will occur later on in the illness. And PCR tends to also be will continue to be positive and persistently positive for some time after disease resolution as well.
Yeah, and speaking of positive tests and negative tests, we hear about false negative tests and false positive tests, especially with PCR results. How do they affect our use of PCR tests?
Yeah, so the false negatives that's the really important one to think about. So they're the ones where the individual, the patient will have a COVID infection, have the PCR test, but then get reported that it's negative. And the reason why that's potentially dangerous, that's the most concerning type of error, is that they can then unknowingly or have a false sense of security, feeling that, okay, whatever sore throat or symptoms I might have is due to something else, and then they're the ones who might not limit their behaviour appropriately because they believe that they don't have it. A false positive is a much more rare event, and the estimates with the current PCR testing in laboratories is estimated to be around 0.001%, and the most likely sources for false positives are contamination in the testing process itself. The consequences of that are, so when somebody doesn't have the virus and then they get told that they do have the virus, there's a chance that obviously it can be quite a confronting thing to be told that you've just been diagnosed with COVID. You could be worried about your family. You may require you'll be required to isolate for a period that you wouldn't otherwise be required for. But I think it's generally accepted that in the context that the very small false positives are sort of quite acceptable, providing that you have low false negatives.
So if I have a PCR test and if I was told I'm negative to COVID, how do I interpret that results?
Yeah, and it's an interesting one because you always need to interpret the tests in accordance with the indications and the reasons why you were doing the test. So, for example, if you were someone who's symptomatic and you add up a respiratory tract symptoms, and then you perform a test, it's reasonably straightforward. You're positive plus symptoms, and then that's enough to confirm a diagnosis. Whereas if you are negative and have symptoms, the assumption at that point is that you have a sufficient viral load to cause symptoms that would then mean that your illness is caused for something else, and then you need to go on a different track and work out what is actually causing the symptoms that isn't COVID. Where I guess it starts to get a little more complicated is when you start testing asymptomatic people and trying to understand exactly what that means. I guess it's generally accepted that sort of large-scale population screening is not really the most effective means of utilising PCR testing, because it is something where it's a finite resource and we do need to make sure it's used most effectively. But if you get someone who's asymptomatic and then let me take one more step back. When the most common reason for testing asymptomatic people is if you've had an exposure. So that means that you may have been in a time or a place where known COVID cases were, or you've had some other contact with a known coronavirus case, in which case the general health advice tends to be that you would then need to isolate for 14 days and then wait out that time to see if you develop symptoms and then potentially have an exit test. If you have a negative test in that after that exposure, the test doesn't necessarily, a negative test in that scenario doesn't actually rule out that you're going to develop coronavirus from that initial exposure. It's potentially useful towards the end of that 14-day period because you can have it be exposed, have the virus and have it be incubating, but it's not yet detectable on PCR. And then it can take some time for a viral load to increase. And that can happen after the test. So if you had an exposure on say day 0, and then you had a PCR test on day 3 or 4 that was negative, it's very possible that you can then go on to start developing symptoms at somewhere around day 10 from that same initial exposure. So whilst it's a negative test at that point is a good thing, it's not definitive. And there have been public health units that have investigated whether or not testing can circumvent a 14-day isolation period. And the general thought at the moment is that it can't, but it can be useful at the end of the quarantine period to confirm that there isn't an evolving infection with very minimal symptoms.
Thanks, Matt. So that goes to show the importance of the 14-day quarantine period, isn't it? And the social distancing. So let's focus a little bit about serology tests that you mentioned earlier. Why aren't serology tests used for diagnosing an active COVID-19 infection?
Yeah, I believe they're used in some countries that may be either resource limited or that they can be used in some context. But I guess the main limiting factor and why we don't use them in Australia is that so from the onset of your illness, it will then take like another 10 days for the test to be positive. And the accuracy and reliability of the testing is questionable. However, it's not useful, or it's not as useful where PCR testing can be positive at the early stages of the illness. So you start getting symptoms, you then would have to wait, a week, 10 days, and then have your test. And then that's a time when the serology you may actually seroconvert at that stage and actually identify it. So it's where we're sort of pushing this test trace and track really early. This is something where you would actually have to wait and delay the diagnosis until late in the infection.
And also because we know not everybody will have antibodies to COVID-19. Yeah. So does that mean they can be picked from a serology test as well? So they're not really effective?
Yeah, that's another really good point too, is that it doesn't provide any information on if somebody's currently infective or not. And I guess the other interesting thing that's being investigated is to what degree of immunity can you infer from the results of a serology test? And at the moment, there's nothing that we can really infer from the results of serology. We don't know how protective it is. Will you get it again? Chances are that you'll probably get some degree of protection. To what degree, we don't know. And then also how long that potentially lasts. Like those are things that are currently being looked at the moment.
Yeah, a lot of things to think about. So in terms of serology test, what are the biggest challenges in addition to ones you touched upon before?
Yeah, so serology testing, I guess, is probably most useful when you're looking at population-wide studies to look at retrospectively what was the potential exposure to a whole population, because not everyone who become unwell will have a PCR test proving that that's what they had. And for example, it might be useful in scenarios where if you have a sporting team, they've been away in a lockdown, and then there's been a high rate of coronavirus infections, and then you're going through to screen a team on the way back in to work at who might require additional workup, or at that point serology could potentially be useful. But I think that we probably need the molecular testing with PCR will be more useful going forward.
Yeah, thanks, Matt. So that's a nice segue back to PCR testing, because I do know you're quite passionate about point of care testing. You have interest in point of care testing. Can you explain to those of us who don't know what it is and what are the benefits?
Yeah, it's quite an exciting thing with how technology is evolving over the last sort of 10 to 15 years. So PCR testing and other molecular type testing is now, as with everything, is being shrunk and simplified into machines and equipment that can be taken out into the field, and it's sort of starting to change the indications for testing and the turnaround times. And we're starting to learn about the importance of the clinician with the patient in front of them at the site being able to have a quick turnaround test and a definitive answer in terms of what their what virus is causing their illness at that time. Because then, if, for example, in the team sport setting, what can happen is testing can help to say you identify early that there's been an introduction of COVID into your team environment. you can find out, and potentially the turnaround time with some of the modern equipment now is within, inside of an hour. And then you can then isolate that person with the definitive knowledge that that's what they have, and then also start the contact tracing process immediately to potentially start to head off second and third generations of cases that might occur if the team continues to have close contact.
It sounds like a pretty great resource to have, but are there any challenges?
Yeah, the challenges are, so the technology is still evolving, and some of the units just aren't, there's still a reasonable cost associated with them, and it might be out of the reach of some sporting organisations, and even for doctors, there's still a little bit of a learning curve in terms of how to utilise the test appropriately and go from the pre-analytical to post-analytical phases to make sure you're doing quality of testing, you've got your quality assurance, you've done your validity studies. So there are still a technical aspect and a learning curve for the physicians as well to be using it. So, but these are, I think, are sort of reasonably small, and they're certainly easy enough to overcome with a small amount of effort. But I think that's sort of the area that I think the field is probably heading in on the whole.
Yeah, that's great. It's always good to learn new things and move the field forward. But I just want to touch up on something you mentioned before, that testing is a finite resource. We do hear about professional sports and elite sports in their isolation bubbles, and that they have access to top-notch testing. But is it ethical?
Yeah, and that's something I've seen crop up a couple of times in terms of, and I think one of the major concerns is who's paying for it as well. Is it being paid for by the public purse, or are they paying for it out of their own pocket? But I think, and that's going to vary depending on which country and healthcare system that you work in. But I think that the main things are that we need to make sure that sport, and we are a higher risk environment by virtue of having larger groups of people coming closer together, that we're not contributing to the overall risk of outbreaks and the healthcare burden overall. And then the manner in which we do that, we're not redirecting resources from higher need settings. So I think those need to be taken into consideration when setting up your own testing resources.
Yeah, thank you. And another thing I would like to talk about is, we often see in the news and in other media outlets, they tend to compare numbers across different countries. For example, we are in Australia, so our numbers are quite often compared against countries like Japan, the UK, and the likes. Are we using these numbers the same?
Yeah, it's they make for very easy sort of sound bites in the news, and sometimes we might get lucky and you might see a number that's changed from like the absolute total gross number that they've provided to a per capita basis, which makes, say, comparisons with smaller and larger countries easier. But the main thing that I think that you need to also take into account is, what are the testing indications in that given country? So, for example, in Australia at the moment, anybody with a symptom so much as a scratchy throat or a runny nose, their doctor can send them off for a test and organise one of those. There are also various epidemiological criteria, exposure risk factors that can result in a test. Whereas there are other countries, their strategy and their allocation of resources is a little different, and they may only test people when they're sick enough to come into hospital, or if they believe that you're at risk for complications. So in that scenario, they are making a conscious decision to allocate their resources differently, and then that will reflect in the total number of cases that they have. So I think that's one aspect of it. The other is in terms of even over time. So countries may choose to allocate their resources differently depending on how the situation's evolving. So how they were getting their numbers, say back in January, might be very different to how the types of numbers that they're getting now, because they're changing their testing criteria. So I think appreciating the testing criteria is a really important thing to understand when filtering and trying to understand the trends in the numbers.
Are we using testing the same?
Yeah, I think each country will use the testing a little bit differently, and it's going to depend on like what is their testing capacity, how many tests they can do per day, what resources they've got, and what their overall strategic approach is. So, and that's going to vary from country to country, and each country will have their experts and decide what is best for them in their circumstance. So, I think that there's certainly a significant variation in terms of how each of the countries are doing it, and that tends to be driven as more by the approach decided and taken, and what practically can be done.
Thank you. And let's talk about another hot topic. There's a lot of discussion going around antibodies and immunity. And having antibodies to a virus or a bacteria doesn't necessarily mean that a person will have immunity to that illness for the long term. So what does that mean for COVID-19 especially?
Yeah, so it's very difficult to conclude anything from the serology testing. What it means is that you've had an exposure at some time in the past. Exactly when, we don't really know, and then we don't know how much protection. As I sort of mentioned before, we don't really know to what degree of protection you may get from a previous exposure. And the other thing that I guess they're looking at is in terms of how long might that protection last, and that has implications for the vaccines that they're currently studying. The current thought at this point in time is that any sort of potential immunity that you gain may hang around for sort of weeks to months, but it's not likely to be permanent, is the current train of thought at the moment.
So we talk about different types of testing, including the point of care testing that has a potential role for risk management, especially in sporting context. So is it imperative that to do the non-technical fundamentals? Because we keep hearing that it is the fundamentals that have an important role, like social distancing. Can you explain the role of these basic non-technical skills and their importance?
Yeah, no, I completely agree. In terms of so the really sort of the high tech side of things, like the point of care testing, is really the icing and the sprinkles on the cake. Whereas the basics of primary prevention, the hand washing, social distancing, staying home when you're sick, those are the things that are really going to stop the infection from spreading through a community or through a population really quickly. The technical things, they're much better at the secondary prevention. So once it's early identification of an infection, to then put in place more stringent primary prevention measures to then stop the infection from spreading even further. So I completely agree that whilst this is the point of care testing is a sort of a really cool thing that's being added to and being developed, we might see more of. Really, it comes down to those basics, which are going to make the big difference.
And also, speaking of testing, we do hear about population-wide surveillance. Are there any tests available to do that? And what's the role of these strategies?
Yeah, population-wide surveillance, like in terms of the molecular surveillance that they're doing in Australia, and I know in some other countries as well, they've done some sewerage monitoring where they'll do PCR testing looking for the virus in different sewerage plants. This is, as far as I'm aware, this is the first time that approach is being used in an outbreak scenario. And the primary function of that at the moment has been to contrast or refute or prove what we're actually seeing from the community level individual PCR testing. So say, for example, if an area has been doing testing and they haven't been able to observe any cases in the last 3 months or so, but they're still finding COVID in the PCR of the sewerage output, then that sort of is an indicator that perhaps that they're missing some chains of transmission. And I know that in Australia, there's been a couple of scenarios where they're looking at where they've identified some COVID in the sewerage that feeds from populations where they don't think, or it's not expected that they would find coronavirus. Some of the other ones that have been looked at is they've looked at environmental samples, taking air samples from, say, the Tube in London and doing PCR on environmental samples from public transport to try and identify. I don't believe that's been as successful as the sewage testing or as utilised, but that's certainly another interesting line of inquiry.
Health advice is evolving with the emerging evidence. So what's needed and what's next can you look into your crystal ball and give us a few tips?
Yeah, I think in terms of the things that are needed overall, obviously is I think a widely available vaccine and some therapeutics. We've got two medications which have shown some efficacy at particular stages of illness. I think that vaccine really will be a game changer, and then it's going to be not only working at how effective it is, when do you need boosters, and then there's going to be issues of actually manufacturing it, distributing it, making sure there's equal access appropriately to it. So I think that's going to be our next big challenge. And I think, as well as we alluded to at the start, is understanding the sequelae of the infection and the long-term circumstances about what athletes find themselves in and what impact that has on their health, their athletic careers. On the whole, I suspect that that's an area that we're going to be looking at for and managing for some time to come. In terms of the overall direction, I think that the point of care PCR, so the ability to do sort of decentralized, rapid, large scale and cheap testing, I think is really going to be probably an area that we'll be heading into over the next sort of 12 to 18 months. And then there's also quite exciting developments in portable whole genome sequencing that will sort of help to understand sort of transmission dynamics in the future. Is I think sort of in my crystal ball as to where things are going to go.
I think we will wrap it up there. And thanks, Matt. It is an absolute pleasure to have you here. And as always, I learned quite a lot listening to you and talking with you. And I have no doubt that our listeners will get a lot out of this podcast. Please forward this on to anybody that you think would gain value from watching it. And if you have enjoyed our podcast, subscribe to stay in tune for upcoming podcasts, and also let us know that what you think of our podcast, or you can suggest topics and guests through the social media platforms. Don't forget that the IOC World Conference on Prevention of Injury and Illness in Sport is now calling for abstract, and the deadline is 1st of October. So head over to our website and have a look. Especially if you are working in this space, this is a great opportunity to share your work. And the conference registrations are also open. So thanks again for listening, and looking forward to see you again soon. Thank you so much, Matt. Really appreciate your time.
Thanks, Tim. Thanks for having me.